Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more. Hi everybody, I'm the Millennial Mechanical Therapist, and today I want to talk about how McKenzie really isn't just about extension. A lot of people, whether it's from ignorance or from poor teaching, believe that McKenzie really is just an extension protocol for the lumbar spine or for the cervical spine, even for that matter. Very often in the literature you see folks going through an extension-based protocol plus manual therapy, an extension-based protocol without manual therapy. Those kind of things are used in the literature to determine randomized control trials and try to find out the effects of certain treatments. Now, that's a very big misunderstanding when that's compared to McKenzie therapy. So unfortunately, folks out there tend to go, well, this research demonstrates that extension doesn't really help that much sometimes. Well, that's completely true if extension is not the direction of preference. McKenzie is really based on the assessment that is done with the patient that first day. As you go through, what you want to do is listen to their history, be interested in what's going on, find out what makes them hurt, what makes them worse. Only then, combining that with a thorough mechanical assessment, really going through all of their repeated movements, can you determine that directional preference. Extension happens to be one of the most prevalent directional preferences in patients with low back pain, but it's not the end-all be-all. For instance, I'll explain a case that I saw previously. Now, I inherited a patient off of a coworker's caseload. Originally, in the initial evaluation, this patient was determined to have a directional preference in extension, was prescribed repeated extension in standing, and given postural correction patient education during that initial eval. On follow-up, the patient had absolutely no change in her symptoms. If anything, she just got a little bit worse. My coworker didn't feel very comfortable continuing and kind of passed that patient on to my caseload. Now, as I went through the assessment with this individual, she was complaining of left-sided low back pain that went into her left buttock. That was all that she had ever complained of. She had never had symptoms down the leg, and she never really had right-sided symptoms that she could recall. She said occasionally she'll get a mid-back ache that kind of goes left and right, but she never had that right-sided buttock pain or anything like that, no hip pain there. So as I went through the repeated movement assessment with her, extension in lying increased her symptoms, no worse, however. So I kind of chased that for a little bit, as that was a yellow light, and I found that to not be very beneficial. So after exhausting that extension, that sagittal plane movement, I started to go a little lateral with her. Now, initially in the teachings and some of basing things off of the quote-unquote the disc model, the idea is that when you bring the hips over initially, you want to close down that side. So if she has left-sided pain, you want to move the hips away so that we get a little bit more pressure there. It turns out with this individual, as I did that movement, she actually worsened. She increased and had more pain in that position. Now for me, that was kind of confusing as I went through, because I went through the assessment and from the teaching from school and reading the books, this was supposed to be the way that it should help. Now, the next step that I took was I moved the hips off to the other direction, and that did absolutely nothing for her. She said it had absolutely no effect on her symptoms, no better, no worse. So what I did from there is I brought her up into standing, and I decided, let's see if weight bearing actually changes this. I went through side glides and standing with some self-overpressure at the wall, and she worsened in both directions. So at this point, I was getting a little bit confused as I didn't really understand the mechanics of her problem too well. Now, on a whim, I brought her back to the table, prone lying, moved her hips offset to the left, so quote-unquote opening that side, and I decided to add some lateral overpressure. originally when she did this movement, there was no overpressure. She was no effect, no effect. So that was actually a yellow light that I didn't catch at that point, and might have just been flustered as I was going with this patient, getting a little nervous as I'm going through, not really helping her too much. So I returned to that position and gave her lateral overpressure, kind of bringing both hands on hips and ribs, giving her some push, some pressure in that direction. With that, she centralized to the mid back. With more repetition, she was able to do repeated extension on lying and ultimately abolish her symptoms. Now, extension was part of that. However, it's not the end-all be-all. Not everybody just needs extension. This patient in particular actually needed some lateral pressure that was almost in a contradictory pattern to what we're typically taught. So my challenge from this video here, I want you guys to think about that. And extension isn't just what you need to give people with back pain. You have to give them a full mechanical assessment and find that directional preference and see if you can centralize that pain. As always, everyone, move early, move often, and move to end range, because that's really where the magic happens.